to our clinic is the metabolic bone clinic. I'm just saying, got it. Oops, sorry. Referrals to our clinic are based on that sort of a thing. So we tend to see younger patients, and we tend to see osteoporosis, not necessarily age-related, but in far younger patients because of the medical problems that the hospital is associated and deals with. King's is also the major trauma center with the hyperacute stroke unit. This is a little picture, and this is a lovely helipad we have here. So we tend to see a lot of disease within King's because it is a referral center for many services. We are spread across 5 hospitals in Southeast London, employing a vast number of staff. Our osteoporosis service mainly sees younger patients. Though the upper limit is 75, we tend to see people right from the age of 18 years of age, middle age, etc. The older or the geriatric osteoporosis, we then move on to a geriatric service. Half our referrals are for secondary osteoporosis, which means that osteoporosis not related to age, but because of other conditions. It could be post-transplant, anorexia, HIV, etc. We run day care services for an infusion clinic. We also have a clinic for a medication called denosumab. We have multidisciplinary team meetings with renal, hematology, bone, or the main people who refer to us. We also support a fracture liaison service, which is an initiative to pick up people who fracture young and pick them up wherever they are. They may be walking, they may come through any, they may be found on the ward. So we offer that advice to GPs so that they can initiate treatment or consider referral rather than, just wait to be referred to our metabolic bone clinic. Right, so a little bit about our osteoporosis. Why is it important? It's a most prevalent metabolic bone condition characterized by low bone mass and microarchitectural deterioration. It is thought that 1 in 3 women and 1 in 5 men will sustain a fracture in their lifetime. And that's quite staggering because fractures are expensive to treat. Not just the fracture itself, but all the rehabilitation that goes with it, loss of work. It's very, very expensive and a big drain on resources. The worst of those are hip fractures because really following hip fracture, the mortality, morbidity is very high. So any initiative to try and pick up osteoporosis, treat it effectively, prevent fractures, or if they've already occurred, prevent more fractures is the priority, okay? So osteoporosis, you have traditional risk factors, and these are quite obvious. For example, age. The older one gets, the chances of having weak bones are higher. So which is why you find older people hunched up, having, loss of height and things like that. Body mass index. Having a low body mass index is a risk factor because of the weight bearing or the lack of it. Women, especially after the menopause, do show some bone loss around the time. Not all of them fracture, but that is a risk factor in the perimenopausal period. Of course, family history, nutritional deficiencies. So these are things which really we can't do that much about or they happen. But other risk factors are, the big one is chronic kidney disease. And we see a lot of it at King's because King's is a place for liver and kidney transplantation. So we see a big cohort of those patients. People with chronic liver disease, those on corticosteroids, malabsorption, endocrine causes like hyperparathyroidism, rheumatoid arthritis, myeloma, all these can result in osteoporosis as a part of the disease process itself. So this is a nice illustration of a peak bone mass. Yeah. If you look at this picture, really we all achieve our peak bone mass until really our mid-20s and 30s. Now, there may be very many people in the audience far younger than me. Maybe you're still achieving your peak bone mass, but for vast majority, it's done. We have already reached it. Then there is a plateau period, and after that, really, it's a downhill, okay? Women tend to accumulate less bone and lose a little bit more bone around the menopause period. A similar trend happens in men, but it is not as exaggerated as in women. So really, the problem is if you don't have enough peak bone mass or you've not accrued enough peak bone mass, either because of nutritional deficiencies, genetic causes, childhood illnesses, even some rare, very rare condition, osteogenesis imperfecta, we don't see much of it. But if you don't achieve your peak bone mass by your mid-30s or so, you have less in the bank and you will tend to lose more. Okay, so it's an important point to make out, because sometimes when people have osteoporosis, we don't necessarily know why it is. There are no real secondary causes, but they just have a low peak. They've never achieved that. And then you always go back and ask them, was your childhood all right? Did you have normal developmental milestones? Did you meet it? Were there any nutritional deficiencies? Were you anorexic? And that happens in, for example, younger people, you know, who've had a poor lifestyle, drank a lot, things like that, or lost rapid weight, lack of periods. All this can affect reaching peak bone mass. How do we diagnose this osteoporosis? Really, osteoporosis is a diagnosis based on a bone density scan. And that's the only way you can diagnose osteoporosis. You can perhaps anticipate someone could have osteoporosis. They look very old, bent over, but the diagnosis is a radiological one based on a DEXA scan. And the DEXA scan is, I'll show you a classic one. This is a typical DEXA scan report, and you will see that is because there are two different kinds of bones, and I'll come to that in my next slide. But essentially, you will see three zones. There's a green, yellow, and a red zone. Red zone means that the bone density in the spine or in the hip is in the osteoporotic range, which is a 2.5 standard deviate below the average mean bone density. So osteoporosis, if you say, how do you define it? It is a T-score or a standard deviate score, which is minus 2.5 times below the average. Now, so this is a very standard report, which you will find for osteoporosis, and you need this to actually make a diagnosis of it. So the reason we have two bones, as was seen in the last slide, is because we are looking at two kinds of bones metabolically. One is a cortical bone, which forms a large bulk of the skeleton, and the other is the trabecular, what's called a cancellous bone. Sorry, was that somebody asking me anything?
No, I think we mute the person who disturbed us. Okay, now.
No problem. No. I'm very, I'm happy to be asked any questions, especially if I'm not. A large part of it is cortical bone, 85%. It forms of the skeleton mass. And this is very sensitive to things like hormone, like, for example, parathyroid hormone, etc. Then there is the trabecular bone, or the cancellous bone, it's called that. And really, the way I try and understand it is, if you have a cancellous bone or trabecular bone has a larger surface area, so it's more receptive to, say, blood flow, cytokines, certain environmental factors. It's a bit like having a lot of curly hair and having very thick, straight hair. Curly hair has more of a surface area. It doesn't necessarily mean it's stronger, yeah? It just has more surface area, whereas you can think of the cortical bone as very kind of having thick, straight kind of hair. sorry, sometimes easy to make these analogies to understand about it. So that is the reason why we look at these different kinds of bones. To diagnose osteoporosis, we have a tool which is known as FRAX. And it is a worldwide accepted tool, which was developed in the University of Sheffield, and it is very good. If you have any time after this talk, just Google this FRAX, and you will look, this will come up, and you can also change it to the country you're in. You know, you can, it's country-based as well, and it takes into account important things like age, gender, body weight, height, if a person's had a previous fracture, and some traditional risk fracture. And there is an area which asks for bone density. And the bone density that they ask for is that of the cortical bone, which is the femoral neck. Okay, so the femoral neck is the bone density we incorporate to get us an idea whether how bad this osteoporosis is, should we treat this patient, etc. And when we put all of this, magically you put enter, and it comes to you with a risk assessment tool, and will give you detailed information whether you, how do you want to proceed? Does this patient require treatment, wait and watch, etc. So I strongly urge anyone, if you're interested, to just have a go at this FRAX tool, which is very good. Now, that's all fair and well, okay? But as I've just mentioned, DEXA is a simple two-dimensional image, okay? Bone is more complex than that. As we speak, we are all having bone remodeling in our body now. There's bone resorption, which is bone loss, and bone formation happening all the time to us, right from birth till the very end. So there are some times where there's more bone suppression of bone formation. So really a DEXA scan is not going to pick up these intricacies, yeah? So do we have something else? So bone remodeling, like our skin, I think we all know that we shed old skin and form new skin. I trust that's quite accepted, right? Thing is happening in the bone as well. So you have old bone being resorbed or lost in the form of what's called as osteoclastic activity. And there's sort of a microenvironment created within bone where osteoclasts come and basically chomp off the areas, which takes a few weeks. And then you have new bone being formed, and that takes a few months. When there's an imbalance, so basically they are coupled. Resorption, if one is, if one takes a hit, like you have resorption is too much, and we'll come to why it could be too much, or bone formation is not much, that imbalances causes osteoporosis or deterioration in bone quality. So you can get excess bone resorption. Postmenopausal osteoporosis is a common thing. Decreased bone formation, glucocorticoid-induced things. So you see, these are all things. And generally, ill health. If one is stuck in intensive care, even for a few weeks, it hits the bone, okay? The bone doesn't, you're not weight-bearing, there are lots of inflammatory cytokines around. All of this can affect, the bone is incredibly susceptible to changes in its microenvironment, which is also the reason why in conditions like cancer, etc., it's also very vascular, yeah? So you can see that it is a very active and a dynamic environment. So this is just a little bit, about osteoclasts, large nucleated cells, which bring about bone resorption. There are certain signals which trigger osteoclasts. They initiate resorption. They create an acidic environment and really chomp up the bone. And during this time, you have lots of release of various products, which I will come to in a minute, which we can harness and help us try and work out, what the bone microenvironment is like. Right, I trust you can see this little diagram?
Yes, we can
or
see.
whatever.
We can see.
Yes, very good. Yes. So basically, this is a very fast version of what is happening to all of us. So you have this chomping of bone and then formation of new bone. And then the cycle repeats again and again and again, taking months and months for each of these cycles to happen. Can we use this to our advantage? Can we think of something which will help us to maybe diagnose osteoporosis, manage it better? Yes, there are some things. So bone turnover markers are usually products of bone. 90% of bone is type 1 collagen. You have other types of collagen in, say, connective tissue, cartilage, even vasculature, etc. But bone predominantly has type 1 collagen. And a lot of, when this is happening, there's lots of chopping of these collagen products, and we can use this as bone turnover markers. Sometimes there are enzymes which are released specifically by the bone. We can use this to see where, at what state the bone is. Is it resorbing too much, which means is there more bone loss, or is there more formation of it? But like hormones, or they're not like cytokines. They don't regulate, okay? They just give us the bones are. They neither help you diagnose anything, okay? They will just assist you with telling you the state in which the metabolic state of the bone. You know, this is perhaps, this audience is very chemical pathology orientated, so you may know this, but sometimes when I do talk to other clinicians or rheumatologists, I say, if you want to know about bone turnover markers, perhaps this slide is very important because you'll at least get an idea of what all these long names are, okay, and what they mean. So this is a triple helix, which is a type 1 collagen. Like any protein, it has a C terminal, carboxy terminal, and an N terminal or an amino terminal. Now, during bone formation, we just looked in a few slides that there is resorption, and after that, the bone has to be formed, which means that this collagen particle has to be embedded in the bone. To do that, it has to be made fit to size, to fitting the bone. And during this time, this peptide, you have certain propeptides which are cleaved from here and they are excreted, okay? Now we harness the fact that these propeptides are released into the circulation because we know that they are cut off from the main peptide, and this central part is going to go and impregnate into the bone, whereas all these are just kind of waste bits, you know, or the other bits which get cut off. And nicely enough, we can measure these, yeah? And all we can imply is this is largely bone related. It's coming from type 1 collagen, which means that if the levels of these are high, that is propeptide of type 1 collagen, P1CP at the C terminal, or P1NP at the N terminal, that the bone is probably in the state of bone formation. So that is bone formation. Similarly, when the same peptide is broken down, there are other products which are released, again from the C terminal, again from the N terminal, and that's CTX, NTX. And these two are markers of bone resorption, whereas the propeptides, which are at the other end here, are markers of bone formation. So it's quite easy. So they are really breakdown products of type 1 collagen, which are the main bone largely being used in the management of osteoporosis. At that, so here is your type 1 collagen. Yeah, that's a serum N-terminal P1NP. The International Osteoporosis Foundation, the IFCC, the International Federation of Clinical Chemists, they do recommend this as a marker of bone formation. And it is measured in the serum. It is an automated assay, not much of a problem, does not have huge diurnal variation, good coefficient of variation, and we can measure these levels quite easily. Because they are formation markers, they are best measured when you give a medication which is bone forming. So if I consider a bone forming medication, and I'll come to that in a few slides down the line, I would measure this to know that, you know what, the treatment I'm giving is effective. The other simple bone formation marker is actually a very humble serum alkaline phosphatase, easily measured, part of a standard liver function test. Half of the serum alkaline phosphatase in healthy people comes from bone and other half from the liver, and gives us an indication. It is a marker of bone formation. It's a marker of mineralization. So it's a good marker. Then we, of course, have a serum bone-specific alkaline phosphatase. So we don't do this general one. We do this bone-specific alkaline phosphatase measured by an immunoassay, a bit tedious and laborious, by ELISA, and it's but useful. And certain organization, for example, KidGo, this is the renal organization, do recommend it as a test along with PTH in those with severe CKD, which is eGFRs, which are less than 30. And we use it quite a bit. I use this especially before I initiate any treatment in chronic kidney disease. So these are formation markers. So I would consider P1NP as an early formation marker, which means that early on in bone formation it comes up, because you know the triple helix has to be chopped, and this one, the bone-specific alkaline phosphatase, is more of a late formation marker. Now we come to resorption marker, which means bone loss. Yeah, so if the bone is being lost, which one is it? So NTX, N-terminal. CTX is widely used. It's measured in serum. It's easy. We measure that sometimes because we run an assay for NTX in the hospital. It's a bit tedious, but we do urine NTX quite a bit. Helpfully, our clinics are in the afternoon, so we do always try and keep a second void urine. And if we keep it consistent, then you know, you eliminate a lot of variation around bone markers. There is another known as serum tartrate resistant acid phosphatase, and we are currently in the process of evaluating it in the context of CKD. And we have done some work on it with our registrar, who's very kindly assessed it. Analytically seems robust, but we want to see its application in chronic kidney. So there is TRAP, but not widely used. If you do need to take away anything from bone markers currently, P1NP, bone-specific alkaline phosphatase are formation markers, and CTX, NTX are resorption markers. So it seems like a great idea, isn't it? You have these, you know, the bone turnover markers are giving you an insight into the actual functioning of the bone. And it seems like, why don't we use more of it? We'll get, we can, you know, we can certainly treat much better. Like most things, they are not without its problems. Okay? There's lots of pre-analytical variability in it. For example, age, gender, ethnicity, pregnancy, lactation, menopause, seasonal, all these kind of things. Yeah, it's circadian rhythm, food intake, exercise, lifestyle. So all of these affected. And if you look at any of the papers related to bone turnover markers, they're always condemned because of the marked variation, even before it comes to the lab. And then, of course, when it comes there, there's lack of standardization. What reference ranges do we do? EQA, is this widely used? So these are all the limitations which prevent it from becoming mainstream. So really, where do we use it? You know, we know they're helpful. They're giving us a peek view into it. Where do we use it? Can we diagnose osteoporosis? Okay. Now, bone turnover markers you cannot actually diagnose osteoporosis because still the definition of osteoporosis is based upon a DEXA scan. What we know is that there's an inverse relationship with bone turnover markers and bone mass. So when the bone turnover, the resorption markers are very high, that means bone is actively resorbing, so bone density is low, yeah? But this association is not very, very strong. There are studies which show that people with high bone turnover markers fracture, which may seem intuitive, okay, for all of us, but again, not strong enough. But actually, you know, sometimes we don't only see conditions, and we use bone turnover markers to try and help us work out, for example, Paget's disease. Some of you may have heard about it. It's disorganized bone, growth, or localized but very disorganized bone turnover. And this, the urine markers, bone formation, resorption markers, very, very high. Whenever the bone turnover markers are massively high, like 3 times the upper limit of normal, of course you can check again, but almost always you're looking at some disease process within the body. We have picked up the odd myeloma when we are investigating for osteoporosis initially from bone markers, and then we send them off, and then, you know, you've got serum electrophoresis, free light chains are all standard screening tools for us. It's not disease specific at all, but it points you in the right direction and lets you go off to investigate this further. Now, can it predict fractures? You know, if we say the bone turnover markers are raised, can we say, oh yes, their fracture risk is high? Actually, here again, sadly, the bone turnover markers don't come out with a strong, oh yes, we can predict fractures. So let's say in a young postmenopausal woman, which is usually, you know, after you're looking at sort of 60 sort of age group, bone turnover markers are quite helpful. Okay, you can say that, right, there is a higher bone turnover marker, osteoporosis on the DEXA. You know what, this lady is likely to have a fracture risk, though your conventional risk calculator, like the FRAX, which I showed you early on, has no section for bone turnover markers. Yeah, that tends to, because it's still not recognized. But we know that in younger postmenopausal women, bone turnover markers are helpful. What about the old, frail elderly? Can we use bone turnover markers? Actually, you know what? In the older people, you don't need bone markers. Some people say you don't even need a DEXA because things like recurrent falls, a previous fracture, loss of height, frailty, all this itself is adequate to know the fracture risk, okay? So it's all clinical. So really you have to apply bone turnover markers in context, right? So the geriatric service we have, which of course we refer patients, as I said, we see younger patients, but they are not ardent fan of bone turnover markers. They don't use it as much, and that is the reason why. So what can we use it for? Now, we can use it as a way to predict response to treatment, or if I'm pausing treatment for any reason, yeah, and I want to know, and the DEXA scan, you know, DEXA takes a long time to show changes. So if you initiate any treatment for osteoporosis, to change on a DEXA or to literally to change on a photograph will take at least 18 months to 2 years. So how do I know treatment is effective in between? That is where bone turnover markers come into play. And that guides you towards the fact that, yes, the treatment you're offering is likely to be effective. Right, so chronic kidney disease is nearly, it could be up to 1/3 of our patients have chronic kidney disease. Chronic kidney disease is associated with metabolic bone disorders. Now, in these individuals, there could be osteoporosis, but there could be also various other forms of kidney disease, okay? Some, largely speaking, kidney disease, bone-related disorders, you can divide them either there is high bone turnover, too much of PTH, and the bone is very active, right? In these situations, suppressing the bone turnover helps. Some chronic kidney disease is associated with a flat bone, like a bone which is unresponsive because of the uremia. And in these individuals, giving osteoporosis treatment, even if they have osteoporosis on a DEXA scan, is a disaster because you are already, the bone is suppressed and you're suppressing it even further, its activity further. So bone turnover markers are very important in CKD, but the problem is with chronic kidney disease, many of them may be anuric, do not pass urine, you can't do a urine test. Byproducts may be accumulated, they're all maybe renally cleared. So it's not very helpful, which is why the research project that we are thinking of is looking at bone-specific alkaline phosphatase as a formation marker and TRAP5B as a resorption marker to see if we can identify patients who are actively losing bone in chronic kidney disease and offer the right kind of treatment. In the olden days, you would diagnose these patients only by a bone biopsy. But as you can imagine, it's quite obsolete now. Okay, so bone turnover markers may have a role in CKD. So really, this is an image of osteoporotic bone. And, on, my right, you want to turn this bone into this. Right? Now, can you do it? That is the desire, but I can tell you it's years and years of treatment. So what is the medical management? So you can either, if there is osteoporosis, they're fracturing, and the bone turnover is very high, we can give them medicines which actually reduce bone turnover. That's the most commonly used type of medication. They're called anti-resorptive therapy. So you have things like oral medication or intravenous ones. So oral generally are alendronate, risedronate, and you have yearly infusions, which we use a lot, called zelendronate. Then you also have a monoclonal antibody called denosumab, which we use. It's a very potent anti-resorptive agent. So this is the mainstream. In very high-risk patients, those with very low bone density, with recurrent fractures, or who have tried this therapy but failed, then we give them the highest pinnacle of therapy, which is called recombinant human parathyroid hormone, and given at small doses for a duration of only 2 years, it creates huge bone formation and an increase in bone.
Primary amenorrhea
and it's a very, very, very expensive treatment, and only very few people can have it. So when we give patients this very, very expensive treatment, I tend to use this P1NP, which I've told you in the slides before, is a formation marker, and to identify those who are likely to respond. So this is a general slide about how we assess patients with osteoporosis. We generally do a bone profile, parathyroid hormone, full blood count, vitamin D, electrophoresis, hormonal profile, celiac screen, because sometimes undetected celiac disease can cause low bone mass, and classify them into low risk, high risk, very high risk. And the FRAX is also helpful to determine this. In low risk people, we give calcium, vitamin D supplements, diet, lifestyle, which can improve bone density, and reevaluate them. In higher risk people, we give oral medications, which also sometimes includes hormone replacement therapy or estrogen receptor modulators, and see how they respond. If they don't respond very well, we go on to step up to more high risk, who are either failed all of this or continue to fracture. We go for teriparatide. This group here, this group here, this group, we use bone markers extensively to help us identify their response to treatment. So there's good evidence that oral bisphosphonates and intravenous bisphosphonates, reduce bone turnover markers, and there are also some predicted thresholds. Okay. Now, in our clinic, we don't particularly use cutoffs to say if they are responsive. In fact, this is one of the things. For example, this is patients who are on teriparatide, which is a formation marker. Really, you find 100% increase, a doubling up of bone turnover markers within a month. And 3 months, it's high, 6 months, it peaks. So, you know, when you find this kind of a response in a patient, you give this very expensive treatment, it is very, very gratifying, reassuring, because you know that they're actively making bone. And when we measure the bone densitometry at the end of, say, 1 year or 18 months, 2 years, we find centimeters are good. So, least significant change, and you know, this audience don't need to know this, because whenever this can be applied to anything, really, any biomarker. So to know that it is actually a response to your intervention, either be it medication, whatever you've included, it should be beyond the least significant change, which takes into account both the analytical variation and the long-term intra-individual variation. So what I'm trying to say is, if you measure a bone marker at baseline, you give a treatment, we measure it always the second time and see if there's been any change. Now, for a urine marker, I usually look for a 50% change. So there is a baseline urine NTX, and instituted a bisphosphonate therapy, albeit oral, and you bring about a 50% reduction in bone turnover markers, and then you feel, yes, the treatment is likely to work, okay? So this helps us greatly to anticipate response to treatment. Very, very useful for patients, because, you know, they need to take this treatment for long term. And it's very easy to forget taking these tablets or not really bother very much, because, you know, how do you know? You've had a DEXA scan, your next DEXA scan is in 2 years. But if you show them these lovely graphs where it is coming down, it really motivates them to keep going with it. So it's very useful for compliance, adherence to therapy, and also for the clinician, for us to have more confidence in the medication. And see how it goes. We had a patient who we instituted many years ago. It was part of my research project looking at P1CP, a formation marker, and P1NP. And this was an elderly lady with severe osteoporosis who took teriparatide, but she wasn't taking it like we expected her to. So she would inject herself, every day. But some days she actually used to massage this injection into her skin. So she never showed the rise in bone turnover marker. And then all the patients we had in that cohort, we had about 8, all of them showed this 100% increase in bone turnover marker except this lady. And we knew there was something wrong. So when she was seen, we realized she had actually difficulties understanding why she should take it every day. We showed her the graph and, you know, and then spot on, she went back on it, took it every day, bone turnover markers went right up, and she had a very, very good response to it, okay? So it does help patient compliance, and it helps them understand, take more ownership of their condition as well. So we can say that bone turnover markers are really, you know, they can't replace a bone density scan, yeah, but they are very good in sort of risk assessing, knowing, you know, how to use it for response to treatment or predict. And I think as chemical pathologists, we need to be more open to it, perhaps. In our own practices, I suppose, at key services to the lab, you know, around our clinical needs, but being proactive and using it, I think is the way forward. They are very, very helpful. There are more and more treatments now coming for osteoporosis, all based on molecular kind of, around bone metabolism. So there's lots of promise for bone markers. The difficulty, they have to be done in specialist sort of, either in a research setting, but I can see that in the next few years, they will find a lot of use, especially when more targeted treatment comes into play. You have anti-sclerostin medications. So often what happens is pharma comes up with some drugs which are based on basic science. And we know that these bone markers have been sitting in the realm of research, but I think they are emerging. We should be more open to their use, fully knowing their benefits and their drawbacks. Thank you very much for your attention. And I think I'm more or less on time. And, if you please have any questions, you ask me. I'm happy to answer them.
Dr. Nandini. Thank you so much, Dr. Nandini, for that excellent presentation. Please be with us. It is time for questions. If you all have questions, you all can talk now.
Yes. Sally, I have one question. Nandini, first, I thank you for your very interesting and informative presentation. Thank you very much.
Thank you.
Dr. Nandini, let me introduce Dr. Gaya. She is the consultant chemical pathologist to the National Hospital of Sri Lanka. She is Gaya Katulanda. Okay,
oh, very nice.
Now.
Oh, very good. Very good. Yes. Oh, thank you.
Thank you, Kisali. Nandini, could you share information about the methods you use to measure these markers?
Yeah. Okay. So most of they are laborious. Okay. So the urine NTX, which they do, they are all ELISA methods. They are we do it in our kind of NTX. We do it in our mainstream lab, but it does require biomedical scientists dedicated to its use. The turnaround time is long. There is no real recognized EQA apart from people who are interested in bone. So we have certain people only measuring this. Within, say, in London, there is Imperial who do it. So they are all ELISA methods, both bone-specific alkaline phosphatase as well as NTX. P1NP is on the Roche, and it is automated, good, quick turnaround time, etc. There is a group in P1NP, because of its quick turnaround, because of its good CVs, and because it's automated, very much, and they use certain cutoffs. We don't do it in our practice, but they use certain cutoffs. And if they reach those certain cutoffs of bone turn, they hand to the GP with plan of action. So I think one of the things which restrict on usage, it's laborious, which is usually ELISA, sort of immunoassay, that kind of thing.
Okay, thank you, Nandini, for that information. Anyway, it's very nice that you have shown that how measuring bone turnover markers will motivate the patients and the users of it. But since these methods are so difficult and they are not automated, it's in a way it's difficult.
That's right. I think it does restrict its use. It's a bit of a problem, it is a big problem. And I particularly find it difficult to not use it, especially in the context of chronic kidney disease, because sometimes not measuring markers and giving injudicious treatment based on bone density scan alone is not suitable. We sometimes will end up doing more harm to the patient. Yeah? If we don't know the basis of their metabolic bone disease. And often what happens is we have a lot of renal physicians who say, oh my God, it's severe osteoporosis. Please start some treatment. And everyone is pressurized to give them, they're fracturing. But they have such an dynamic bone. How do you know that? You know that measuring markers of bone turnover. I suppose, I don't know, do you measure any within your labs at all?
No, we are not doing that. In Sri Lanka, at least in state hospitals, we don't measure this.
Yeah.
But the population with osteoporosis is high.
Yes.
So we don't have like prevalence data, but we see a lot of osteoporotic fractures and
correct. Yeah.
Renal failure, renal
yes.
disease is also common.
It's very common. That's right. Yes. Yeah. And the thing in the UK, of course, is the elderly population is, preferentially very high. Longevity is more. So you have a lot of older people. Of course, that's not relevant to my clinical practice, but even then, osteoporosis is very prevalent. So I think there is a role for this. If we were able to measure these things easier, and with time it may become that way, a lot of automated assays take their birth in research labs, isn't it? And over years they get better.
Hopefully.
Hello, Dr. Nandini. I'm Dr. Chandrika. Actually, thank you very much for your very interesting lecture at making an interesting topic. Actually, it was not an interesting topic for me. And I have one question. Can you hear me?
Yes, I can hear you.
Yeah. Now, you said about this, when you were talking about these bone markers, you measure least significant change, 50% for urine and 30% for serum. So what is the time gap between, what
that's a very good question. Okay, so what tends to happen is when usually, look, it's both clinical, can't keep bringing patients back. It's just not enough resources to see them that frequently. So usually we initiate treatment and have follow-up within 4 months or so. Okay. You will find a change. In fact, in research settings, they say as quick, depending on the agent you use. If you use the oral tablet, oral medication, you would expect at least about 2 to 3 months, you will see changes in bone turnover markers. Yeah. Say, for example, in intravenous thing like IV zolendronate, very quickly, you will find the changes in bone turnover markers within weeks. Denosumab, which is a subcutaneous injection, which we give every 6 months. In research settings, they would also within days, you would find changes in bone turnover markers. So they're very, because they act quickly, they act quicker, the parental. Similarly, say suppose someone has fractured, you find the bone markers are upregulated greatly. So it depends, or you give HRT and things. So any treatment you have, you will find changes if you measure it, right? We do sources to keep, measuring, shall we do it in few weeks and things like that. So we tend to usually measure at 4 months time and see if, the bone markers have changed. And if we are doing serum, if you get a 50%, say, reduction in bone markers, you're very happy. You then discharge the patient back to the GP with a plan saying, you do a bone density scan halfway through the treatment. So it's an adjunct. It will not replace a DEXA scan, right? It'll at least give you confidence to know that the treatment here instituted is working. And you make a plan.
Okay. And another small question, if I have
Yes, there are reference ranges, and of course they are based on, for example, NTX. It's very wide. It's based on premenopausal women, who aren't on any oral contraceptive pill and things like that. There are established reference ranges, but there's lots of discussion around it. Yeah. So if urine NTX, we have a reference range which is quite high. It's sort of something like about
is high.
Very, very, very wide, say 6 to 65 equivalent, bone collagen equivalent per millimole of creatinine. Now it's so wide. Where are you looking at? This is where I think the least significant change comes to play, because it doesn't matter what the reference range is. If you're bringing a suppression of 50%, you're okay. And equally, if you find the bone turnover markers at the upper end of the reference range, in a young postmenopausal woman, that again raises alarms to me, like, oh, I think this person is likely to be losing more bone than otherwise. Yeah. But yes, there's always this thing around reference ranges and things. But for P1NP, serum CTX and urine NTX, there are reference ranges.
Thank you. Thank you, Dr.
Any more questions? Okay, I think it is time to end the meeting.
Yes.
I invite Dr. Dilanthi Varavita. She is the Joint Secretary, CCPSL. She is a consultant, chemical pathologist, Faculty of Medicine, University of Colombo. She will deliver the vote of thanks today.
Thank you, Dr. Kisale. I hope that you all can hear me.
Yes, we can hear you.
Okay, thank you. So on behalf of the CCPSL, let me take this opportunity to thank Dr. Nandini Rao, consultant in chemical pathology and metabolic medicine at King's College Hospital, UK. Thank you very much, Dr. Nandini, for delivering this excellent presentation amidst your busy schedule. And please accept our token of appreciation, which will be sent to you in few days' time. I also would like to thank Dr. Ruvini Ranasinghe, currently working at King's College Hospital, London, for coordinating this event. And finally, I thank all the participants who joined with us from all over the country and asking questions and making the discussion very interesting. And so that's all for today. So hope to see you all in another interesting webinar in 2 weeks' time. And thank you very much.
Thank you very much indeed. It's a great pleasure to be amongst you. And King's is always open to have lovely people come and visit us. So, I'm sure we can, you've already established, but it will always be nice to have interested people to collaborate with.
Thank you so much, Dr. Nandini.
Thank you.
Bye-bye. Thank you.
Bye.
Bye.